Assalamualaikum warahmatullahi wabarakatuh and a very good morning. A warm welcome to all participants from Malaysia, the SEAMEO network and affiliated countries to today's webinar. The theme today is the tale of food and drug allergies and evolving concept and mechanisms. Our presenters today are from Allergy and Immunology Research Center, the Institute for Medical Research under the National Institute of Health, Ministry of Health, Malaysia. I am Dr. Masita Arif, Head of Allergy and Immunology Research Center, IMR, and it is my pleasure to be the moderator for today's session. Ladies and gentlemen, as many of you may know, I would like to take this opportunity again to share that the aim of this webinar series is to share the knowledge, discuss topics on biomedical research, and present research outcomes. I would like to explain a little bit about the theme for today's webinar, which is the tale of food and drug allergies. An allergy occurs when your body's immune system sees a certain substance as harmful. It reacts by causing an allergic reaction such as runny nose, sneezing, itchiness, swelling of skin, and redness of eyes. Substances that cause allergic reactions are called allergens. The allergen can be from the environment or aeroallergens such as dust mites, pollen, can be also from food and even drugs. Some allergies are seasonal and others are year-round, and some allergies may be lifelong. Please allow me to announce a few housekeeping messages from the Secretariat before we start with the two interesting presentations today. First, we will not be taking questions during the presentation. However, the participants may ask questions using the link that we have shared in the email and YouTube channel. Secondly, we will have the question and answer session conducted right after the end of both presentations. The attendance link is also provided for those who like to receive an e-certificate of attendance. It is available at the YouTube description section, and you may fill in your particulars using the provided link. Ladies and gentlemen, for today's webinar, we have two speakers. Our first speaker is Dr. Mohammed Faizal Bakhtiar, Medical Officer in Immunogenetic Unit under Allergy and Immunology Research Center, IMR. Dr. Mohammed Faizal is an experienced researcher with expertise in drug hypersensitivity. He has been involved in many studies on drug hypersensitivity, such as genetic susceptibility of non-steroidal anti-inflammatory drugs or NSAIDs-induced urticaria or angioedema. He has published on drug hypersensitivity in many reputable peer-reviewed journals and presented his research findings in many international allergy and immunology conferences such as Apache, ASEA, and others. His research interests include pharmacogenomics, allergy testing for antimicrobial stewardship, genotype, endotype, phenotype of NSAID hypersensitivity, and anaphylaxis. And as for today, Dr. Faizal will be sharing his research experience in his presentation entitled Drug-Induced Anaphylaxis, Does It Always Have to Be IgE Mediated? Dr. Faizal, the screen is yours.
Thank you, Dr. Masita, for that kind introduction. I'll share my slide now. Okay. First and foremost, I'd like to thank the organizing committee for inviting me to speak to this for this webinar and share my experiences in drug-induced anaphylaxis. Just to put it out there, this is not actually a detailed presentation on anaphylaxis, but rather just to highlight the salient features of drug-induced anaphylaxis and to create awareness that it is not always IgE mediated. So this is my conflict of interest statement. In relation to this presentation, I declare there are no financial or non-financial conflicts of interest, and I'm not affiliated to any pharmaceutical company. So to start off, as always, we start with the definition of anaphylaxis. There are variations with minor differences, but the most widely used is a serious life-threatening systemic hypersensitivity reaction that evolves rapidly to 2 or more organ systems that might cause death. So it is traditionally described as an IgE-mediated reaction. As you can see in this diagram here, you can see there's actually the initial contact with the allergen, the sensitization phase, and then the production of IgE. And then subsequent exposure to the allergen will cause degranulation of the mast cells. Okay, my apologies here because this diagram is slightly inaccurate. Actually, there should be a cross-linking between the allergen and the IgE to actually cause the mast cell degranulation. Okay, when you talk about anaphylaxis, you think about IgE, but this has actually baffled clinicians, researchers alike, because some anaphylaxis reactions occur on first exposure. So we can see the evolution of the classification into this diagram that I put up here, which is IgE dependent and IgE dependent, independent, which is can be categorized as a immunologic classified as immunologic reaction, and also the non-immunologic reaction, which is actually directly affecting the mast cell through various receptors such as the MERP-PRIX2 and opiates and things like that. Okay, so the IgE dependent reaction, as I said just now, is due to subsequent exposure through the high affinity Fc epsilon R1 receptor, and IgE dependent is usually during first exposure, but sometimes it is actually a subsequent exposure, but because it is a hidden allergen, therefore it appears to be first exposure. I'll explain that later on. And also the non-immunologic reaction, which is a direct mast cell activation through the MERP-PRIX2 receptor activation, and also for NSAIDs, skewing of the prostaglandin leukotriene axis. And to complicate things, anaphylaxis is actually influenced by cofactors such as exercise, alcohol, NSAIDs, and hormone. Okay, so this diagram is just to show that the main players of the of anaphylaxis and the current known mechanisms of anaphylaxis. So as you can see here, these are the direct triggers of mast cells, and then this is modifiers such as hormones such as the estrogen, and also the trigger through complement that triggers the mast cell from the complement, and then the involvement of other immune cells such as neutrophils, macrophages, activating the platelets, and then producing platelet activating factor, which is actually a direct trigger of the mast cell. And from this platelet activating factor, it causes a vicious cycle producing anaphylaxis. Okay. So these are the common drugs involved and the putative mechanism. As you can see here, it is IgE mediated. It can be IgG mediated, skewing of prostaglandin leukotriene axis, and also the MERP-PRX receptor, and also complement activation related pseudoallergy, also known as kappa. As you can see here, it looks complicated, but it's actually not. You can see that certain drugs actually activates the mast cell through many means, meaning it can be IgE mediated or IgG mediated and complement or MERP-PRX receptor, such as the neuromuscular blocking agent, which is muscle relaxants. It can either be IgE mediated or it can stimulate the mast cell through the MERP-PRX2 receptor and also IgG, just recently discovered. but also, like for instance, the polyethylene glycol can also produce IgE-mediated reactions, complement activation-related pseudoallergy, and also through the IgG mediated reaction. Okay. So this is the point of contention. Basically, this has been talked about many times, and is of interest to many people. I'm just going to zoom in to the currently talked about COVID-19 vaccine, which is the mRNA vaccine. So as you can see here, there are many components of the vaccine. Basically, it's a packed lipid, and the predictive immunogenicity that can cause the reaction is pre-existing anti-pack IgM, IgG, or IgE immunoglobulin or antibody, and ionizable lipid through the pathogen-associated molecular pattern receptors, which is the PAMs of the innate immune system. Neutral lipid, which is the just basically it's just the lipid activating the complement system, and also the mRNA itself, which is actually a potent PAM receptor activator. Okay, so I've just put up this diagram here just to show that pre-existing antibodies such as the anti-pack IgM or IgE is actually disadvantageous because it can actually cause the classical anaphylaxis, or it can actually activate the mast cell through the complement, okay, via non-classical anaphylaxis. And it can also be advantageous. The pre-existing antibody can be advantageous because the complement IgG or IgM bound to the lipid nanoparticle enhances endosomal uptake and mRNA translation of spike protein and the HLA presentation of spike protein peptides by antigen presenting cells. Okay. So what can we do to actually diagnose when people report drug hypersensitivity or vaccine hypersensitivity? We can do skin testing, drug provocation tests, and for the in vitro tests, we can do tryptase level during the acute reaction, and basophil activation test, and also the complement activation. For the skin testing, usually we use a non-irritating concentration, and these are the things that we need to know before starting skin testing. You have to discontinue certain drugs before testing. It involves either skin prick or intradermal, and intradermal usually we use a very low concentration, which is 1 in 1,000 or to 1 to 100 for the drug known to cause mast cell activation. Okay, and perform only when the prick test is negative for the intradermal. And we also do not do skin testing immediately, but we actually wait about 4 to 6 weeks to reduce false negative reaction, and this can go up to about 6 months. Okay, and during the acute stage, the clinician can actually send the tryptase level to actually confirm whether it is anaphylaxis or not. But absence of tryptase, raised tryptase level does not exclude anaphylaxis. It's basically clinical. Also, for drug provocation, it is the gold standard of drug hypersensitivity testing, but you have to balance this with the risk-benefit ratio in the individual patient. So the indication of drug provocation tests is to exclude hypersensitivity in non-suggestive drug hypersensitivity history to provide safe alternative, or if you want to exclude cross-reactivity between related drug in proven hypersensitivity such as beta-lactam, NSAIDs, things like that, and to confirm diagnosis in the suggestive drug hypersensitivity history, but negative or inconclusive non-validated allergy tests. Most often after negative skin test, you this is basically the drug provocation test is actually performed often after a negative skin test due to ethical consideration, and it is performed whether in graded incremental doses, or you can actually do a test dose, or you can directly challenge, or you can re-challenge. So I'm not going to go into great detail on this. Okay. And then the basophil activation test is actually an in vitro test. It's on live cells on the basophils using the marker CD63, CD203C, and also what we are currently experimenting now, the MRP-PRX2 receptor for muscle relaxants. And of course, the complement activation that we are setting up soon for the vaccine complement activation reaction. Okay. So what does this all have on the impact of the management? So this I've actually outlined these few things that we need to actually consider. If it's IgE mediated, it is total avoidance. Of course, because it's IgE mediated, so there's minute amount of drugs can actually cause anaphylaxis, so total avoidance is actually advocated. Okay, but currently there are a few studies that actually followed this patient up and found that as the time goes by, the IgE actually wanes. So it's quite interesting that as the years goes by, like for instance for beta-lactam, when the IgE disappears, you can actually tolerate it in, let's say, 15 or 20 years down the line. So it's not actually absolute. And this has been shown from many studies currently. And also careful reintroduction for the IgE IgE independent reaction, careful reintroduction. We have done this for NSAIDs hypersensitivity because it's not an IgE mediated reaction. We have actually introduced the NSAIDs carefully, basically. Because when it is not IgE mediated, usually it is dose dependent and infusion dependent as well. So you can introduce it carefully, okay, and with a reduced dose. And then I'll touch just a bit on the antihistamine as a mast cell stabilizing pre-medication. Okay. Just to touch on this, for NSAIDs hypersensitivity, we have actually used antihistamine as a mast cell stabilizing pre-medication with a reduced dose to actually reintroduce the patient to the NSAIDs if there are no alternatives. And of course, the role of omalizumab, which is actually an anti-IgE monoclonal antibody So this one is very interesting as recent studies have actually highlighted the use of omalizumab in allergic asthma with NSAIDs hypersensitivity. So when you when you give omalizumab to these patients, the IgE falls, and you can actually reintroduce the NSAIDs to these patients. Okay. And the next impact on the management of these patients, usually the labeling strategy. How do you label this? Because it is very important, as if you wrongly label patients with these patients with drug hypersensitivity, you will deny good drugs being used on patients. So for example, if let's say beta-lactam, you have to find an alternative and try to label only to the implicated drug, not as a sort of a cross-board labeling, so that you can actually use a very good beta-lactam alternative. Okay, so I think that's about what I'm going to talk about. This is just to acknowledge that this is the people that I've worked with, from the immunogenetics unit, Dr. Tan Lei Kim, Dr. Tu Chun Lai, Dr. Siti Aisyah, Dr. Nurul Ain, and also our collaborators, Dr. Tamim Moon from Dermatology Department, Kuala Lumpur Hospital, Malaysia, Dr. Kwok Fan Yin from Anesthesia Intensive Care, Kuala Lumpur Hospital. And also I've worked with Miss Brenda, mostly for the in vitro tests, and also Dr. Cindy Thomas Joseph, who has now left HKL for Pantai Hospital. Thank you very much. Okay, back to you, Dr. Masita.
Thank you, Dr. Faizal, for the interesting talk. If there is any question that you would like to ask about his presentation, kindly fill up the form using the link given in the YouTube description section as mentioned earlier. Next, I would like to introduce our second speaker for today, Ms. Brenda Leecyous, a research officer from Allergy Unit, Allergy and Immunologic Research Center, IMR. Ms. Brenda holds a master's degree in biotechnology from University of Malaya. She has presented her works in multiple local and international conferences. She also published multiple works in peer-reviewed journals. Her current research interests are on molecular allergology and allergic disease mechanism. It is our great privilege to have Ms. Brenda with us to share her research. Her presentation is entitled Food Allergy, When You Need the Bigger Picture in Allergy. Over to you, Ms. Brenda. The screen is yours.
Good morning, everyone. And thank you, Dr. Masita, for the kind introduction. And also, I would like to thank the organizing committee for giving me this opportunity to share and give a small talk about our research on food allergy. Today, on the first half of my presentation, I'm going to give you some insight on the current scenario of food allergy. And on the second half, I'm going to focus on one of the food allergy research that has been carried out in our lab. This is my disclosure. I don't have any conflict of interest to disclose. First, let us look at the prevalence of food allergy. The prevalence of food allergy is reported approximately around 10% worldwide, and this number can also be applied regionally. If we look at the countries across Asia, among the main causes of food allergy are shellfish, cow's milk, egg, peanut, and tree nuts. And on a serious note, the type of food responsible for food-related anaphylaxis in children is cow's milk, whereas in adults, shellfish is the most reported culprit. Currently, crude allergen extracts are widely used as test allergen in diagnosis of allergic disease. crude allergen extracts are obtained from various allergen sources such as pollen grains, house dust mite, or cat dander. There are several questions arising from using crude allergen extracts for allergy diagnosis. First is, can we use these extracts to identify the true cause of sensitization? And secondly, does it help us to tell the severity of allergy symptoms? And ultimately, can it help us to give a better patient's management? Over the past recent years, there is a change of paradigm in allergy diagnosis workup. The progress in molecular biology over the last decades has allowed the identification and characterization of single allergen in detail at molecular level. And there are several factors that warrant the use of allergen molecules compared to crude extract. The first is the allergen molecules has enhanced the low abundance or missing molecules in crude extracts. And secondly, allergen molecule has improved analytical specificity and allow additional clinical assumptions, for example, increased risk association or clinical severity. And thirdly, the allergen molecules can also has become sensitized to, and therefore we can induce the specific immune tolerance and therefore treat the patient. So now let us look at one of the studies that we have carried out. We conducted a laboratory-based study entitled Development of Local Shellfish Allergen to measure specific IgE antibodies in shellfish allergic patients. This study was fully funded by the Ministry of Health Malaysia. It was led by me, co-investigated by Dr. Zalatul, Dr. Faizal and Dr. Normalin. Our aim in this study is to biotinylate local shellfish allergen on streptavidin matrix and compare with commercially available immunoassay. Shellfish allergy is the leading cause of urticaria, angioedema, and anaphylaxis in allergic patients. Shellfish make up the most relevant source of allergens implicating food allergy in Malaysia, with unique characterization to the region. Currently, commercially available immunoassay used to diagnose shellfish allergy are using shellfish allergen species that are common in Western countries. Due to geographic variations, none of the species are locally consumed, for example, shrimps, crab, and squid, and therefore the employed assay may not accurately represent local allergen source and consequently affect diagnostic accuracy of shellfish allergy in local populations. So in this study, again, our aim is to utilize the locally produced shellfish allergen extract by coupling on streptavidin matrix for specific IgE quantification in allergic patients, and therefore by using accurate molecules, we can give correct diagnosis and give proper management. In this study, we used 3 different types of allergens, which are shrimp, crab, and squid. Basically, what we did is that we biotinylate the extracted allergens and we couple it on streptavidin matrix and carried out some concentration optimization work before we proceed with specific IgE quantifications in patients and control serum. In this study, we used a total of 86 patients and 83 control serum. So here on the most right, just to give you a visual on how the streptavidin matrix looks like, the streptavidin matrix basically sitting inside a cap embedded in nitrocellulose membrane, and what we did is that we coat the streptavidin matrix using the biotinylated extract, and we proceed with specific IgE quantification in patients and control sera using the already available automated platform. Based on our SDS page analysis, we observed prominent bands between 20 to 100 kilodalton in all extracts, corresponds to major allergen in crustaceans and mollusks. Among the major allergen in crustaceans and mollusks are tropomyosin, arginine kinase, myosin light chain, sacroplasmic binding reticulum, troponin C, triose phosphate isomerase, and hemocyanin. And also, in all extracts, we have demonstrated prominent bands between 37 to 38 kilodalton, indicating a major shellfish allergen, tropomyosin. We also studied the influence of molar excess of biotin level on specific IgE results, and we found out that labeling at approximately 5-fold molar excess of NHS biotin is optimal, and that if we go lower or higher ratio, it will give us a lower specific IgE results, and this could be due to the mass epitope effect. If we now look at the figure on the left side, this is the comparison of specific IgE antibody in patients and controls for both biotinylated extracts and corresponding commercial assay. And as we can see, all controls sera were negative when tested with biotinylated squid extract with commercial assay using another species, another squid species in 15 patients, and it reveals a close correlation of 0.96. But because we work with a very small sample size, we couldn't really draw any conclusion from that. Our current work have demonstrated close correlation between biotinylated allergen and commercially available immunoassay, and this method is particularly useful for measurement of specific IgE to local allergens that are commercially unavailable. The knowledge we gain from developing this tool has provided us some basis for designing specific immunodiagnostic tools and perhaps immunotherapy in the future. It is also noteworthy that this study is limited by the utilization of crude allergen extracts and also by the absence of double-blind placebo-controlled food challenge data, which is important to confirm food allergy diagnosis. And besides that, we also work with a limited number of sample size. Apart from the study that we have just discussed, we also conducted another concurrent study to isolate two allergen proteins from prawn and crab, and they are tropomyosin and arginine kinase. We have reported some part of our data, and the rest of the works are still pretty much ongoing. I would like to thank Dr. Zala Tulhani and Dr. Normalin for the concept of this presentation, and I also like to thank everyone, especially allergy team, for making the research content possible. And if you have any research inquiries with regards to allergy or food allergy, you can email to any of the addresses stated here. And with that, I thank you for your attention.
Thank you, Ms. Brenda, for the insightful presentation. We will now be moving to questions and answer session. Please keep sending us your questions, and I will be picking few questions to ask our presenters. And it seems that we have received a few questions from our audience. For the first question is for Dr. Faizal. After first dose of Pfizer, I developed severe anaphylactic shock. May I ask you, is it safe for me to take Sinovac then, Dr. Faizal?
Okay, thank you, Dr. Masita. So this is the mRNA vaccine with inactivated vaccine Sinovac. So basically, Pfizer, the ingredients in mRNA vaccine, which is the Pfizer that the audience asked, and Sinovac is very different. Like I said just now, Pfizer contains mRNA and lipid peg, and basically those are the two, and basically some other like saline and things like that. Okay, for Sinovac vaccine, it contains the inactivated virus and adjuvant, aluminum hydroxide, and probably a little bit of ethanol, if I'm not mistaken. So the ingredients are very different. So the allergenic component in mRNA, like I said before, is the mRNA itself. It could be the PEG lipid, which is the most allergenic component of the vaccine. And Sinovac does not contain this. So currently, if you follow the guideline, we can actually switch to Sinovac and receive it safely. But since we do not advocate for mixing vaccines at the moment, if you switch to Sinovac, you have to actually restart the regimen. So when you give the Sinovac, you actually start as the first dose again and receive the second dose of Sinovac again. Okay, that's my answer.
Thank you, Dr. Faizal. For the second question, I think this one I give to Ms. Brenda. It's a very simple question, Ms. Brenda. Is the skin allergy test in IMR available for public? If so, whom should we contact? this question about the skin allergy test that we conducted in IMR, right? Miss Brenda, can you please answer the question? Thank you.
We for skin allergy tests in IMR, we have our allergy clinic in Specialist Center, Hospital Kuala Lumpur, and we are taking referral case, so you can check our details online, and you can also contact ENT Hospital Kuala Lumpur to book for skin allergy test. Yeah, that's the answer.
Thank you, Miss Brenda.
Thank you.
So the third question, Dr. Faizal, for those that had anaphylaxis experience to NSAID, non-steroidal anti-inflammatory drugs, will they get hypersensitivity to mRNA vaccines such as Pfizer? If the patient receives Sinovac vaccine without any harmful side effects, it is safe for the person to get Pfizer booster as what recommended by the authorities. It seems there is two questions, I think, here, Faizal.
Yes,
So please
okay.
answer.
Okay, the first question is about anaphylaxis to NSAIDs, whether it's safe to receive mRNA vaccine. Okay, let me just explain to you that NSAIDs has got about 5 phenotypes. So if you say anaphylaxis to NSAIDs, most likely it is actually IgE mediated to the NSAIDs. And usually when it is IgE mediated, it's only one family of the NSAIDs that is actually contraindicated in these patients. As for the rest of the NSAIDs, most prevalent for patients to actually have is actually the cross-reactive of what we call cross-intolerant reaction, which is not IgE mediated. In such cases, patients will actually develop reactions with different NSAIDs with different chemical properties. So they may cross-react, and mostly they will react to the non-selective NSAIDs. So now when you say anaphylaxis, I'm assuming that it's actually IgE mediated, and usually from my experience, the IgE mediated reactions are usually to the COX-1, usually to either ketorolac or sodium diclofenac, which is IgE mediated. And some concoctions in overseas may contain PEG. Okay, but in Malaysia, the NSAIDs that we have here do not contain PEG. So I think if it is a cross-reactive reaction, you can actually receive the mRNA vaccine safely, no problems. Okay, you just have to be observed longer for any reaction, because you can predict this kind of reaction. Okay, because if you have had an allergic reaction to some drug, there are studies that actually show that you have a higher, just a little bit higher risk of developing another type of drug reaction. So that's why you have to be observed longer. This is actually has been put up in the guideline as well. And then the second question is, if the patient receives Sinovac vaccine without any harmful side effects, is it safe for the person to get Pfizer booster? So you mean the first dose is Sinovac, and then the second dose is Pfizer. So at the moment, we are not advocating mixing vaccines, because the data for vaccine mixing is quite limited. There are evidence, good evidence, that it is actually quite good to boost the immune system, but the evidence is limited. So if, let's say, you received Sinovac safely, I would really recommend for you to actually receive the second dose as Sinovac at the moment.
Okay, thank you, Dr. Faizal. Now to Miss Brenda, there's one question here. Both tropomycin and arginine kinase abundant in seafood as major allergen. Miss Brenda.
Thank you, Dr. Master, for the question. Tropomycin and arginine kinase, in fact, has been identified as a major allergen in seafood. And we have previously reported that these two proteins are the main cause of allergic in seafood allergic patients, and also part of the reason why we focus our work on isolating these two proteins, where we've been working to develop a recombinant allergen for these two proteins. Yeah, it is in fact the most abundant allergen in seafood, and also have been identified and reported as major allergen in seafood. Yeah, I hope I answer your question. Thank you. Back to you, Dr. Master.
Thank you, Miss Brenda. Dr. Faizal, question about, do you have any experience or any study of allergy in COVID-19 patients?
Okay, that is actually a good question. We haven't actually seen or been referred with patients. I mean, I think that the question is whether post-COVID-19 disease, isn't it? That you experience allergy. We haven't actually seen or being referred to, but we have actually been referred after vaccination actually, but the causal is actually not the association of the causality between vaccine and also allergy has not been determined. Okay, basically it is not associated with allergy to vaccination, but not to COVID-19 patients.
Okay, thank you, Dr. Faizal. I think the reason why we don't have any study of allergy in COVID-19 patients, because of course it's quite difficult also to manage the investigation, because as you know, people with COVID-19 patients can infect others, right? So that's why not so many studies done on that. Okay, and then I think I have one more question maybe for Miss Brenda. Why is the difference between milk allergy and lactose intolerance? I think people always confuse about milk allergy and lactose intolerance. Miss Brenda, can you please answer the question? Thank you.
Thank you, Dr. Masita, for the question. There is difference of, in fact, there is a difference between milk allergy and lactose intolerance, and this term has been used interchangeably. For milk allergy, the milk allergy usually caused by IgE reactivity to the protein inside milk, such as casein, alpha-lactalbumin, and beta-lactoglobulin. Whereas in lactose intolerance, individual with lactose intolerance usually having this condition where they have insufficient level of lactase enzyme to process the lactose sugar, so they develop symptoms like diarrhea and bloating. In fact, the milk allergy individual usually do not benefited from consuming lactose-free milk, because in lactose-free milk there will still be the major allergen inside the milk, so they will still be reactive to the allergen in milk. So milk allergy and lactose intolerance is definitely two separate entities, and milk allergy is due to IgE reactivity to milk allergens such as casein, alpha-lactalbumin, and beta-lactoglobulin, and lactose intolerance is due to a lack of lactase enzyme to produce the lactose sugar, and they also lead to different clinical symptoms. Yeah, I think I hope I answer your question. Thank you, Dr. Masita.
Thank you, Miss Brenda. So Dr. Faizal, I think we have one last question for you. Is it okay? After this, we can
Yeah.
conclude.
Yeah.
Okay. Do you still give adrenaline for IgE independent or non-immunological anaphylaxis?
Okay, that's a good question actually. Actually, clinically, you can't actually, hang on, you can't actually distinguish between IgE independent or IgE dependent anaphylaxis. So I will still advocate adrenaline use for all clinically suspected anaphylaxis, whether it is IgE or IgE independent reaction. This is because when you give adrenaline, it is more to actually counteract the pathophysiology of the acute reaction following the anaphylaxis. It's not actually to either block the IgE or block the receptor, IgE independent receptor. So I will still advocate use of adrenaline regardless. Okay, thank you, Dr. Masita.
Thank you
Okay.
very much. I'm afraid that is all the time we have for questions from participants, and thank you for your participation in the Q&A session. We hope that this webinar has shed light on some research work that we are conducting at our institute and would spark interest and could initiate research collaboration with others. Ladies and gentlemen, now we have come to the end of the webinar session. I would like to thank all participants for their support to make this session successful. You must subscribe to our National Institute of Health Malaysia YouTube channel and click for notifications whenever there is a new post. Before I conclude, I would like to announce that we will have the next session of IMR-SEAMEO webinar series on the 26th of September. So can mark your calendars. The theme for the next webinar is Prioritizing Environmental Health for Healthier Communities in Global Recovery. We hope you can join us at the next session. Until then, many thanks from all of us at IMR. Take care and stay safe. Bye, everyone. Thank you very much.